My dear friends, this is going to be my own personal experience on ABPM, what I have been using for few years. ABPM came to work by 2011 NICE guidelines, which has clearly given that the ABPM is a better device to diagnose hypertension, especially in diabetic hypertensives. Soon followed by other hypertensive societies, and also now by Indian Society of Hypertension. That is one of the important tools in making a diagnosis of hypertension in your practice. This is in reality what we see in a patient. We tie the apparatus. Is a person is working in a grocery shop. Now he actually have put on the dress. You can see how well it has gone inside. You don't see what exactly he is wearing. But in sooner, we may get a simpler devices. We may get some chip-like things. So we can do many patients with the ambulatory blood pressure monitoring. Now, when you check the ABPM in a patient, at least there must be 14 BP readings in the daytime, and there must be at least 7 BP readings in the. It's a minimum requirement to check the blood pressure through ABPM. And if you compare the office BP readings versus ABPM, they are not the same. See, the staging of hypertension by NICE guidelines, stage 1 hypertension by your office BP reading is more than 140 by 90, which is equal to 135 by 85 of overall ABPM measurements. Stage 2, you could see the difference of 10 millimeters is 160 by 100 by your office measurement is only 150 by 95. So it's very important. You should know that if you have a 150 systolic, it is equal to 160 systolic of our clinic blood pressure monitoring. Of course, the systolic isolated is 160 by 90, not 140 by 90 as per the NICE. And the severe hypertension in both is 180 by 110. The standards of recommendations for the normal and abnormal blood pressure, which has been alluded by Dr. Vishwanathan. As you could see, the daytime is 135 by 85. It should be lesser than that to say they are having a normal blood pressure. And the night time, it should be about 120 by 70, less than 120 by 70. Even a slight degree of increase in the night, say 125 by 75, which tells you that the patient has got hypertension. And 24 hours overall is 130 by 80. This is how the unrecorded chart, which shows you how your BP will be recorded by the machine in your own practice. If you could see that the daytime blood pressure is 135 by 85, which actually dips down by 15 millimeters systolic and 15 millimeters diastolic. From 135 it comes to 120 in the night. From 85 it comes to 70 in the night. In fact, this circadian BP rhythm is physiological. This physiological dipping is very essential for the normal health of a patient, because if you see the causes of dipping in the night, the decreased sympathetic outflow in the night, decreased stress and stress hormones in the night, relaxed muscles and decreased baroreflex, increased natriuresis in the blood by the kidney, and all the end organs take a perfect rest under low stress. And this rest is important to prevent target organ damage. If you don't have this physiological dipping, the organs also on shared rest in the night, then you go for the damage. This is physiological and your normal circadian rhythm. And I'll show you some of my ABPM patterns, and it's only my personal collection from Indian diabetic hypertension subjects. I'll start with the case report. I'll also tell you how do you record this blood pressure, ambulatory blood pressure monitoring, and how do you give a report format to the referring physician, what exactly the patient is suffering from and what is his cardiovascular risk. Look at this case report. 43-year-old Mr. R was referred for ABPM. History of type 2 diabetes 5 years. No history of hypertension on several office visits. Non-smoker, non-alcoholic. Father died at the age of 54. So he has a family history of premature coronary artery disease. This patient had some sort of dizziness or a giddiness 15 days back. His family doctor suspected that he had probably a TIA, and he underwent elaborate investigations because he got scared that he might follow his father's feet. MRI brain and MRI cerebral angio were normal. Carotid and intima Doppler, vertebral Doppler were normal. Audiometry and ENT examination were normal. Echo showed borderline LVH. That's very important. And ECG normal, including treadmill. HbA1c was 6.8. Thyroid functions were normal. HDL cholesterol was 26. And TGL was 230. And LDL was 110. He's got a dyslipidemia. And urine show no microalbumin. So his doctor is worried wherever the patient is suffering from a masked hypertension. So he said, I'm suspecting this gentleman because he's got a left ventricular hypertrophy of unknown origin. We'd like to do ABPM for him. Masked hypertension, already said, it's called white coat normotension. The other terminology for masked hypertension. Some patients have a raised blood pressure in the clinician's office, but normal BP in the clinician's office, but ambulatory BP readings will show hypertension. This is how the patient's recording came. At a one snapshot, it looks almost normal. It looks almost normal. Then we went into the particular ABPM recording. We dissected it. We thought we'll see what exactly is suffering from. Now his total valid measurement is 30 out of 33. Normally you must have a 90% of the recording should be perfect. Then we take it granted. Otherwise we have to repeat the ABPM. ABPM recording normally 80 to 85% will become alright. Another 15% we have to repeat it because of this invalid measurements. So the valid measurement should be above 90% to say is a valid measurement. And his heart rate is all the time 90 to 108. Look at the heart rate here. This heart rate is depicted on the right side in the red lines. You can see his heart rate is all the time sinus tachycardia. And his pulse pressure is only 38. Any pulse pressure more than 55 is very significant. And what is the cause for tachycardia? His thyroid function tests are normal. And this tachycardia was not detected by the physician who referred the case to me for ABPM. Any high pulse pressure is a big risk factor for cardiovascular disease. Any 10 millimeter increase in the pulse pressure increases the risk of major cardiovascular complications and mortality by 20%. Very important. So must know, when you give a drug treatment too, that should not increase the pulse pressure of the patient. Some medications for high blood pressure may actually increase the pulse pressure and increase the cardiovascular risk. Now we come back to our case again. The daytime blood pressure in this patient by ambulatory blood pressure monitoring is 127/89. But what we have to know is that the patient's BP, if it is anything 135/85 is supposed to be normal. But this patient already in the daytime has shown a mild diastolic hypertension. Instead of 85, his BP is 89, diastolic blood pressure. That's point number one, the observation number one. So the nighttime blood pressure in this gentleman is 130/92. Look at the blood pressure here, the recording. But what we expect in a normal individual is 120/70. There's such a vast difference. This patient has got a systolic hypertension in the night, diastolic hypertension in the night. He also has got a diastolic hypertension in the daytime. Now his mean day blood pressure is 106 millimeters. We always check the mean blood pressure. You know how the equation to say mean blood pressure. The mean blood pressure should be always between 60 to 100. Anything deviates from 60 to 100 carries a very 60 to 110 carries a very bad prognosis. His mean nighttime blood pressure is 110. It's almost the normal mean arterial pressure is 70 to 110. So this patient's nighttime BP comes to close to 110. That means he's already reached the high mean blood pressure. So the mean blood pressure indicates hypertension control 24 hours, daytime or nighttime, and mean BP less than 60 and mean BP more than 110 carries a very adverse cardiovascular risk factor. Now we have come to the conclusion the patient has got a tachycardia, number one. He has got a daytime diastolic hypertension. He has got nighttime systolic and diastolic hypertension. And already his night mean blood pressure has gone to the maximum. Innocuous looking ABPM has shown you such insight. Now coming back to the same patient's ABPM. His standard deviation is 9 millimeters. Any standard deviation from the mean blood pressure, it should be between 6 to 12. It's got a normal standard deviation. So the standard deviation is given by an equation which we can calculate as well as the machine also will calculate and tell you. So the normal standard deviation from the mean BP is 6 to 12 millimeter and any standard deviation of 1 millimeters on either side, the cardiovascular risk increases by 40 to 50%. So standard deviation increases the mean systolic blood pressure, the cardiovascular risk increases by 40 to 50 for systolic blood pressure, and standard deviation for the diastolic blood pressure increases the cardiovascular risk by 30 to 35%. I'll tell you a terminology what we use in ABPM, we call the BP load or the person time elevation. Whether BP was all the time elevated, we call 24 hours and it's called 100%. If it is partly, say 30% time it is elevated, 60% time it is elevated. So PTE and BP load are synonymous with the terminology whatever you've been using. And it means the amount of blood pressure higher than the normal defined limits. When the BP is higher than the normal, all the 24 hours is the PT is called 100%. When the PT is more than 25 to 30%, it is considered elevated. So, ladies and gentlemen, a patient need not have all the 24 hours have hypertension to cause some harmful effect to your system. Even a PT of 25 to 30% is sufficient to produce some cardiovascular risk in a patient. PT or loads more than 50% indicative of can cause left atrial hypertrophy. So what is the PT in our patient? The daytime systolic PT is 18% normal. Nighttime systolic PT is 67%. Already 67% of his time in the night time the patient is in systolic hypertension. His daytime diastolic PT is 46%, again very high. Even 30% is significant. It's got a 46% of the daytime diastolic BP is high. And nighttime his PT or BP load is 100%. So what we thought a very innocuous looking ABPM. Now if you summarize, the patient has got a tachycardia, daytime blood pressure, diastolic, nighttime systolic blood pressure, nighttime diastolic blood pressure. Then his mean blood pressure in the night already has gone to the maximum of 110. And if you could see the PTE or person in the night time is almost 67% and 100%. Coming back to our patient, this is what very important the previous speaker, Dr. Vishwanathan, has been alluded to. I told you the patient's BP should dip in the night by 20 millimeters. From 135 it comes to 120. From 85 it comes to 70. But look at the patient's here, the status. This fellow, instead of dipping, in fact, he rises from his dipper status. So this patient has got, in fact, minus 4.6. Minus 4.6. That means the patient has got a reverse dipping. It is opposite to the dipping. See, this is what the classification, what the previous speaker already has shown the slide. When you have a normal range is 10 to 20%, it's called the normal dipping. Anything which is less than 10% to 0 is called the non-dipper. Less than 0%, we call it minus 4, minus 6, then it's called reverse dipping. When it goes more than minus 10, then we call nocturnal hypertension. Then anything more than 20% more dipping is called extreme dipping. If you give a lot of drugs in the night, what will happen? The blood pressure will tend to dip more than the expected. Then the end organ perfusion suffers. So especially in an elderly person, you try to give a lot of drugs in the night and try to bring down the blood pressure. Sometimes they go for extreme dipping. So non-dipping causes are the old age, cognitive dysfunction, diabetic people are non-dippers, obese people, we call it obstructive sleep apnea, endothelial dysfunction, and renal hypertension, dysfunction, and left ventricular hypertrophy. In some patients, the normal nocturnal blood pressure rises above the daytime pressures rather than falling during the night. These patients, also called reverse dippers or risers or extreme non-dippers, have worst cardiovascular prognosis. Our patient belongs to this particular group. He doesn't dip, in fact, his blood pressure rises. So what looked like very innocuous, our patient belongs to this particular group. What it looks like a very innocuous ABPM curve. Now when you summarize, it's called a diastolic hypertension at daytime, systolic and diastolic hypertension during nighttime, high normal mean arterial pressure, BP load of 67% systolic and 100% at nighttime diastolic, and BP load of 46% diastolic at daytime, extreme non-dipper, in fact riser. Already echo has shown it's got a left ventricular hypertrophy. His father has died at the age of 54. This patient is diabetic for the past 5 years. If you don't treat this patient, we know the prognosis. This patient belongs to a very adverse, a danger dynamite group. So, in fact, we miss this patient, gentleman, if he has not been referred for ABPM, if he has not referred for intervention. So, we looked at the patient's profile, then we stayed with the patient, we discussed with him, then we started the blood pressure medications for the patients along with the lifestyle modification. This is a normal 24 hours ABPM which shows the normal dipping pattern. Some of the quiz here. Okay, anyone want to participate? We have a few minutes left.
Yeah.
Anyone want to come to the mic? Please come to the mic. Anyone? Few people interested? Anyone? Please come. Come to the mic. Faster. We have time left. Not much time left. Okay, I'll show you the first slide, then you can participate on the next slides.
I think we can, we have Dr. Viswanathan, he can apply for the first time maybe.
What you see here is the white coat effect. This patient has been tied off his BP cuff. He was there in the hospital for a few hours. As he goes home, the BP has come to normal. This patient also has got a non-dipping at the night time. White coat hypertension, I already told, is 10 to 30%. And we overestimate the blood pressure, over treatment will be given. In fact, nice guidelines had come only to see that white hypertension people, they save about 5 billion pounds in 5 years' time. Somebody else wants to take a participation in this quiz? Anyone? These are my real, true cases. Anyone? This is called the morning surge. You can see the BP is almost there and then extreme. You can see the difference between the diastolic and the morning blood pressure. So the morning surge, as I told you, it causes myocardial infarction, sudden cardiac death, stroke, both hemorrhagic and thrombotic strokes. And antihypertensive drugs, they provide BP control. The early morning surge should provide a greater protection against the target organ damage. But this particular morning surge is still a blind spot. If you try to treat a drug treatment at the night time, what happens actually, it causes nighttime dipping and causes more morning surge. So we have still no specific drugs to target the morning surge. What you see here is called the nocturnal hypertension. So the reverse dipping, when it is more than 10%, we call nocturnal hypertension. It's called a stage 2 hypertension. The nocturnal hypertension, although the daytime ambulatory blood pressure is a good predictor of outcome, a number of studies have shown that ambulatory nocturnal hypertension is associated with the worst cardiovascular outcome. If the patient cannot say, I cannot wear this all the 24 hours in my office, at least tell him to come in the night, evening hours. Ask him to wear it and then you can remove it in the morning. So even the NICE guidelines now recommend, the British Hypertension Society says, the patient cannot willing to do that, you can at least do a night ambulatory BP monitoring and then check what exactly is happening. And reducing the nocturnal hypertension, if you give a dietary potassium and magnesium supplementations and sodium restriction to restore the normal dipping. One fruit which contains a lot of potassium and magnesium is banana, but unfortunately, we have the diabetic people. We can't advise them routinely the banana. Otherwise, all people with severe hypertension, non-diabetes, we can recommend bananas. The consistent lowering of the nocturnal BP by a thiazide diuretic AC inhibitors or angiotensin receptor blocker is a potential therapeutic strategy for reducing nocturnal hypertension. Reducing nocturnal hypertension, the consistent lowering of the nocturnal hypertension by a thiazide diuretic AC inhibitor or angiotensin blocker is a potential strategy. And from the evidence available that there is a need to clinically practice to use antihypertensive therapies with proven 24-hour duration of action with a superior nighttime BP coverage as demonstrated by the OSCAR trial with amlodipine and perindopril or by olmesartan in the Orion trial. This is one of the few good drugs to control the nocturnal hypertension. Stage 3 hypertension, deeper state preserved. This is one of the beautiful cases. You can see the BP variability. Very unfortunate you are not participating. There is a discussion on either side. This slides could have been more interesting. This patient's got a grade 2 hypertension, non-dipping, wide pulse pressure, BP. You know the prognosis in these patients are very grave unless you really treat them with a good set of drugs. Reducing the BP variability results in prevention of stroke. Calcium channel blockers and diuretics are the drugs of choice to reduce the BP variability. In fact, beta blockers worsen the BP variability as told by the life study. I do not know about the modern beta blockers. The combination of BP variability and ISH always results in intracranial hemorrhage. Somebody has got ISH plus BP variability, we know is a candidate who is prone for intracranial hemorrhage. Beautiful slide actually. This is a beautiful slide. This patient had come to the clinic. His BP was normal. You tied the BP, had gone home, then the BP started rising. When you come back to the clinic, the BP has come down. We call this condition masked hypertension. Again, extreme BP variability, stroke range hypertension. As you can see, the systolic is almost about 180, and then you can see the diastolic almost 120, and it's a medical emergency. I'll stop with this particular one discussion because there are some cardiologists here who may be able to help me. This patient was referred to me for as a case of hypotension. His doctor all the time records his BP is 100 by 80 or 90 by 70 or 110, and he is referred for hypotension. A case of post-MI, and he was in he had undergone a coronary artery bypass surgery. In fact, he was in stage 2 cardiac failure. He was on AC inhibitors and a very good dose of carvedilol. If you could see the pulse rate, I'm sorry. You could see the pulse rate here is almost titrated to around 50, around 70, 80. So his BP was quite stable. The patient was very, very asymptomatic and he was comfortable. You want me to continue the same drugs? He has been taking ramipril, he has been taking the carvedilol, no symptoms. His BP is only now around 90 by 70, 100 by 80. Are there any guidelines to say what is the BP to be set for these patients? Stage 2 cardiac failure.
Yeah, there are the recent ACC-AHA guidelines published in the last week.
Okay, we have said that BP less than 130 by 80 is desirable in patients who got a cardiac failure or CAD, and BP less than 120 by 80 is again considered. This patient, we didn't do anything. We told him he's doing absolutely fine. Let him go ahead with his drugs. His perfusion was normal, his kidney functions were normal, he was able to do his routine small activities. Do you have any time left or we stop with this, sir?
We can have some time for discussion now.
Okay,
Thank
fine.
you.
Then I think if it is there, I can stop. I have some few more slides to show to you. We'll see it in the discussion. We have time, we can show it to you. Thank you very much, sir. Thank you for the...
Thank you, Dr. Lakshmanan and Dr. Viswanathan for nice presentation on the ambulatory blood pressure monitoring. We all